everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, is pleased to welcome you to our October NDUS Presents webinar on perceptions of naloxone among urban opioid users in 3 cities. The NDUS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. I believe that both of them are in the audience with us this afternoon. My name is Erin Artigiani, NDUS Co-I. Barbara Kerr, Marwa Al-Nasir, and I will be the facilitators for this webinar. We are part of the NDUS Coordinating Center team based at CSER, the University of Maryland in College Park. For those who are interested, you can find detailed information about NDUS, recordings of prior webinars, and invitations to future webinars on our website at www.ndus.org, www.ndews.org. You will also find instructions for how to join our NDUS network and participate in ongoing discussions with more than 1,600 experts and concerned citizens from across the United States and many other countries. We developed the NDUS Presents webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. Today, we are excited to be joined by 3 researchers addressing the knowledge, attitudes, behaviors, and practices related to bystander naloxone. Our first presenter will be Dr. Lee Hoffer from the Department of Medical Anthropology at Case Western Reserve University. He will be presenting on findings from his NDUS hotspot study in Cleveland, Ohio. He will be followed by Dr. Kavita Babu from the Department of Emergency Medicine at the University of Massachusetts Medical School, and Dr. Annabelle Belcher from the Department of Psychiatry at the University of Maryland School of Medicine. They will present on their findings from Worcester, Mass. And Baltimore, Maryland, respectively. These 3 studies were initiated by NDUS to test the feasibility of rapidly exploring important research questions by expanding ongoing NDUS hotspot studies and other fielded studies. We worked closely with a group of researchers with extensive experience working with opioid users to create a questionnaire with standard domains and questions that were included in each of the studies being presented today. The 5 domains addressed in the questionnaire were knowledge about naloxone, access to naloxone, experience with naloxone, perceptions and attitudes of opioid users about naloxone, and the influence of the availability of naloxone on drug use behaviors. This webinar will be approximately 90 minutes long, and we encourage you to submit questions during and after each of the presentations. However, please do not raise your hand because we will not be able to respond to you that way. Instead, we ask that you please post your questions in the Q&A box. We will hold a Q&A session after the presentations. Our presenters, Barbara, Marwa, and I will do our best to get to all of your questions. A recording of this webinar and copies of our presenter slides will be made available on our website, www.ndus.org. So look for them under the Resources tab in about a week or so. Thank you, and we hope that you will enjoy this NDUS webinar. Dr. Hoffer, I will turn things over to you now.
Great. Thank you, Erin, and I'd like to start by thanking NDUS for the opportunity to participate in the hotspot study as well as sort of this naloxone sort of sub-study. I'd also like to thank my co-authors of this report for sort of the work they put into this project, and the findings are sort of all of ours. So next slide, please. So the methods for the project were, we conducted 30 open-ended interviews with active drug users in Cuyahoga County, and we recruited them through the syringe exchange program here in Cleveland. And the participants were not in any current residential or inpatient treatment and had injected at least 5 times in the last 30 days. We usually interviewed them for anywhere from 45 minutes to an hour, and they received $20 payment for their participation. Next slide. So the first thing to note is that not all the participants recognized the term naloxone, but were familiar with the term Narcan. And most reported that naloxone was available, and they were aware that they could access it at the syringe exchange program. Many thought that it should be made more available, but most people had kits and sort of a common factor limiting naloxone access related to limited transportation. The next slide, please. So the majority of participants described obtaining naloxone through the distribution program, DAWN program at the syringe exchange program. So as far as availability of naloxone, I think there's sort of some issues there as far as the sample goes. But all the participants reported that the local DAWN program does a very good job distributing naloxone. Next slide. As far as the attitudes and awareness of naloxone and how it changed and influenced drug users' behavior, most participants had experience being revived or reviving others with naloxone, but experiences varied considerably, and some people had a number of them, and a couple of people had few or had none. So a lot of these experiences made people reflect on their own use, but did not affect their drug use behavior or drug habits. It didn't seem to pattern, naloxone use did not seem to be a factor influencing their drug use patterns. And the majority viewed naloxone as positively as sort of a lifesaver. Thought everyone should be carrying naloxone. Here are a couple of quotes from some of the interviews. It's a lifesaver if you need it. It's great. It saves lives. So I can't say anything bad about it. Next slide, please. Many of the participants described naloxone as a safety net to have in emergencies, but not something that enabled their use. Some reported awareness that people who don't use opiates view naloxone as enabling reckless use, but interviewees were adamant that this is not typically how they were affected by naloxone. And the quote here is a nice one, I think. No one thinks like that. It's there in case something happens. Pretty much a regular using heroin addict knows what they do every day, what they need to get right, get off sick. They know the amount they are using, they are used to doing what they need to do. Next slide. Some participants maintain a negative attitude toward precipitated withdrawal brought on by naloxone, but generally had a positive attitude about it. There was no stigma associated with being revived by naloxone, and there was gratitude expressed for the availability. I think, thank God, somebody was there with Narcan for you. You then, after that, if you were brought back with Narcan, do you really want to go through that again? Some participants reported that drug use behaviors were influenced more by the increase in presence of fentanyl in the heroin supply. This is a big issue here in Cleveland, where actually heroin was not available. Most of the heroin was now mixed with fentanyl. And the problem was that people talked about, at least, or the users talked about, was they had to use more frequently because fentanyl didn't last as long as heroin. Some participants viewed repeated revival with naloxone, however, as a sign of less responsible drug use. I think we'll go to the next slide. So most participants express feeling of increased comfort and safety in their drug use due to having naloxone. However, some noted that naloxone does not guarantee overdose survival, especially when using fentanyl or heroin adulterated with fentanyl, or heroin adulterated with fentanyl. However, beyond naloxone, participants were motivated to take additional harm reduction measures, which we thought were very interesting. They were using fentanyl test strips. They're also taking test or multiple small injections, and they were trying to use more in the presence with others, even though they did talk about using alone. Next slide. Okay. Naloxone use seemed to be part of a general pattern of being much more cognizant of the high risks associated with opioid use, and this again was sort of influenced by the presence of fentanyl. So naloxone's not a get out of jail free card. Don't nobody want to play Russian roulette with their life. Narcan came on the scene and everybody is grateful. People are grateful for it because they get it to live another day. Without Narcan, lots of people would have died. Next slide. Opioid injectors viewed naloxone as an important tool for saving lives. They talked about increasing access as far as the implications of these findings go. through community settings, and this are to some more diverse populations, potentially African Americans. They also looked at peer distribution programs as a potential way to sort of expand distribution. And then people who use opiates are taking more measures to protect themselves from overdose. And sort of there needs to be more education on sort of safe drug use practices, as well as fentanyl-specific harm reduction measures such as test strips, information on the variable potency of the drug and drug mixtures and warnings and things of this nature. Next slide, please. Participants did not know about the Good Samaritan laws here in Cleveland or how they offer protection. And many of the participants did not call EMS for overdoses. A lot of times they were concerned of any sort of warrants that they had out for their arrest, so they weren't quite sure how that worked with the Good Samaritan laws. And then finally, just the last couple of notes. Illicit fentanyl has really crowded out heroin in Cleveland. So users often assume heroin is fentanyl, or heroin is always combined with fentanyl or carfentanil in some cases. So this creates really an untenable sort of risk environment, but it's really unescapable for people who are using opiates. So people who are aware of the extreme risks associated with this new market, yet were unable to change the conditions. And so in this case, naloxone was very helpful. And then finally, participants were aware of the public narratives that naloxone fosters reckless drug use. So we thought that was an important finding to report. Thank you.
Hi there, I'm Kavita Babu from the University of Massachusetts, and I am an emergency physician and a medical toxicologist. Our setting is unique. We are in a tertiary care level 1 urban emergency department where we see over 135,000 patients per year. And it was in this setting that we were able to recruit the 10 patients that I'll talk about here. One thing about our area is sort of just like Dr. Hoffer said, we're in a fentanyl endemic region. And so a lot of our participants have reported their experience with fentanyl rather than heroin. With respect to our methods, in our cohort, all of our interviews were audio recorded, and the audio recording subsequently underwent a HIPAA compliant transcription. For the preliminary report that we provided and that you all will have access to, that was based on review by our study staff. With respect to the senior staff briefing, we went on to perform a qualitative analysis, developing codes based on priorities, as well as the preliminary report. We had 2 independent coders, our research coordinator, Ms. Brittany Chapman, as well as our research assistant, Ms. Melissa Taylor. They met to review consistency, and then the agreed upon codes were entered into in vivo. We conducted an applied thematic analysis, completed with oversight from Dr. Rosen, and the summaries of key topic areas were generated. For their participation in this study, our participants received a $10 gift card to a local business. And in our study, or in our cohort, excuse me, one of the interesting things is that we were looking for patients who had presented to the emergency department for an opioid use disorder related complaint. We specifically had 4 individuals who presented after a near fatal overdose, as well as 6 individuals who presented for other complications of their drug use, for example, for soft tissue infections. Next slide, please. With respect to awareness and availability of Narcan or naloxone, to give you a sense of our landscape here in Massachusetts, patients do not require a prescription in order to obtain Narcan from a retail pharmacy. So in our setting, all participants were aware of Narcan by brand name, although one individual was unfamiliar with the term naloxone, and all of them had actually received some form of naloxone training. All but one participant reported that they had a kit in their possession, or they had previously carried a naloxone kit. And quotes related to that, one individual noted, "If someone needed it, I would rather have it than be powerless," while another said, "I want to help others. I'm not just walking around with this for the hell of it. I'm going to try to save a life." The sources of naloxone that were reported included sober houses, treatment programs, syringe exchanges, and retail pharmacies. Participants in our cohort were aware of the Good Samaritan laws, but the knowledge and level of confidence in police adherence varied. In Massachusetts, the Good Samaritan law allows for individuals to call the police or EMS, pre-hospital personnel, in an overdose without fear of being prosecuted for a drug-related charge, specifically drug possession. However, some of our participants reported that other charges could be levied, specifically with relation to child protection or with relation to weapons charges. So quotes that we heard: if you get caught with somebody, if they're both high and you are using and he is using, they can't arrest you. Trust me, the cops don't follow the Good Samaritan law. 7 of our 10 participants reported having previously received naloxone at least once in their lifetime. When asked about self-administration of naloxone, none of our participants had ever self-administered or known anyone who had. The quote that we heard repeatedly was, "I don't think that's possible." Barriers to naloxone administration. So our participants administering naloxone included fear of legal repercussions, not having it readily available, and wanting to avoid interrupting another user's high. Another barrier that was identified was just sort of a lack of education. And I think a lot of people think they're going to get in trouble. I think not enough people have Narcan, even though there's so much access to it. All participants who previously reported receiving naloxone described an intensely unpleasant physical response, consistent with precipitated withdrawal, as Dr. Hoffer mentioned previously. And the descriptions were fairly vivid, that this was an incredibly aversive experience. So I can't describe anything else like it, and you literally feel it ripping all of the opioids out of the receptors in your brain. I was extremely, extremely sick and like violently shaking, and it was horrible. What was interesting for me is working in an environment where we frequently see patients presenting after near fatal overdose was the emotional response that was described. And 6 of the 7 participants who reported previously receiving naloxone described strong emotional responses in the post-naloxone period. I kind of hate myself for overdosing. You feel like you do, and withdrawals, the depression, anxiety, and all that stuff, kind of embarrassing and degrading. And you know, it's upsetting. I've kind of ruined my life because of my drug use. It's tough. It's life or death. You got to get clean. None of our participants reported an increase in their own drug use, frequency, or dose when naloxone is present. Our participants did say that they felt safer when naloxone is available, but again, that aversive feeling about the consequences of receiving naloxone and precipitated withdrawal were clear. There was a vague perception that others might increase their drug use in the presence of naloxone, and as Dr. Hoffer mentioned, they were aware of that narrative, but we did not find any of our participants endorse similar thinking. So I've never seen anyone that wouldn't already do heroin because they have naloxone. They were going to do it whether they have it or not. It doesn't change the thinking. I guess it's safer knowing that if you do overdose and someone's with you, they can administer Narcan to you and you don't die. Nobody wants to be Narcaned. And the rest of that quote, it doesn't make people think they can use more because they can have their life saved by Narcan. Nobody wants Narcan. Next slide, please. This was very interesting to our team in terms of the counseling that we provide for patients with respect to naloxone reversals. One of the issues that was raised more than once was the idea that a barrier to administering naloxone is trying to decide whether the individual is having the desired effect of the heroin or fentanyl, or whether they're truly developing signs of heroin or fentanyl toxicity, specifically related to respiratory or central nervous system depression. The indicator that came out repeatedly in our population as a result was color change. And so our patients reported looking for some sort of cyanosis, bluishness of the lips in particular, in order to decide to administer naloxone. Their lips turning blue and purple, and they sleep, and when they're out, they're out. And by that time, they're gone. The interesting part about that second quote is that we know that cyanosis is a late finding in hypoxia. And so it sounds like in our patient population, in order to get proof that this is an overdose and not sort of a desired effective use, there may be a fairly long delay before naloxone is administered. Additionally, there was the perception that immediately after naloxone, users might seek out additional heroin or fentanyl to mitigate precipitated withdrawal symptoms. So this is a little bit different than Dr. Hoffer's team's findings in the sense that while it seems like for some of our participants, there was no stigma to receiving naloxone towards individuals who had received naloxone, other participants told us that they worried that in the immediate post-reversal state, users may be looking to acquire drugs in order to sort of treat or ameliorate their withdrawal symptoms. Now you have someone who's sick who wants your dope. She's like, after you withdraw the drug, you're gonna want more. And I said, are you crazy? I don't want no more. But after I withdraw, I say, if you give me more, you don't wanna do it, then you do it. Next slide. Participants felt that heroin they use the term to refer both to sort of traditional heroin as well as fentanyl and the analogs, and that fentanyl is typically not desirable. In our community, as in Ohio, it sounds like what we're seeing is that, I like the way Dr. Hoffer described it, that heroin has really been crowded out. And so our users were reporting an inability to find heroin, even if that's what they wanted. I don't think there's any real heroin left. Unfortunately, they also described the need to use repeatedly if they were using fentanyl rather than heroin due to its shorter duration of effect. In fact, nobody even wants fentanyl because it only lasts a very short amount of time. In our community, again, we found that participants were resigned to the fact that fentanyl is unavoidable and associated with an increased risk of death compared to heroin. Our participants did not have any standardized ways or methods that they use in order to determine whether or not they were using heroin or fentanyl. And really, again, sort of that resignation. Unfortunately, that's the only thing around now, and that's why everyone's overdosing. So with respect to implications for education or intervention, our participants clearly found naloxone aversive, and that idea that in some cases was described where our participants would say that they were even a little more careful when naloxone was available because they were so afraid of being reversed is a narrative that we think can be leveraged in changing public perceptions regarding harm reduction efforts that try to support the idea that there's more high-risk drug use associated with the availability of naloxone. From our perspective, again, in terms of naloxone distribution and counseling patients on overdose recognition and the appropriate actions to take, emphasizing indicators that differentiate the high from an overdose for drug users when crafting our interventions, specifically underscoring that cyanosis is a late finding in naloxone training scenarios. We also need to address concerns that carrying naloxone signals that this person may not be stable in recovery or their recovery might not be successful. The idea that you are unable to self-administer naloxone is one, again, that I think is helpful in promoting this concept that just because you're carrying naloxone does not mean that you intend to use or that you may return to drug use. It really is a signal of your willingness to save someone else's life. Next slide, please. With respect to methodologic pearls that we took away from this study, one of the challenges is that we did try to use some Likert style questions with our population, and particularly in the individuals who had recent near fatal overdoses, the attention and concentration that are required for completion of Likert style questions seem much more challenging than asking these qualitative questions and allowing them to express themselves more freely. We would suggest that before the deployment of any additional Likert skills in our population, again, immediately after an overdose or presenting with an acute illness, that cognitive interviewing and optimizing the mode of administration may be essential. But I think that most striking, we appreciated the opportunity to participate in this study and are thrilled to see the concordance of qualitative themes across the site. I'd just like to thank our study team, Dr. Lai, Dr. Goldfein, Ms. Chapman, Ms. Taylor, Dr. Rosen, Dr. Carrero, and I'd like to introduce Dr. Belcher from the Baltimore site and the University of Maryland Opioid Treatment Program. Thank you.
Thank you very much to all three sites. We really enjoyed participating in this, and we thank you for the opportunity. I just want to acknowledge my co-authors on this report. Tom Cole's a research assistant who worked with me extensively, especially with some of the qualitative assessment of the data. Alexander Pappas is a fellow in our addiction treatment program here. Sophia Kozak is a fourth-year medical student. And then we had fellows Raman Sandhu, Rachel Steer. Aaron Greenblatt is our medical director of the drug treatment program, and Eric Weintraub is our division director. So I'm coming from the University of Maryland, Baltimore. We have an opioid treatment program. Yeah, if you can click through rather quickly, Aaron, please. It's the first hospital-based treatment program actually established in 1972. So we've been dealing with an opioid crisis here in Baltimore for several decades at this point. Our treatment program is a Maryland Department of Health certified CARF accredited level 1, so an outpatient opioid treatment program. And in addition to psychosocial, group, and individual and psychiatric services, the clinical care here involves dispensation of federally approved opioid treatments, which include methadone, buprenorphine, and Vivitrol. Next slide, please. Oh, and we do have over 500 patients that walk through our doors daily, so that's an important thing to note. Methods, we recruited from our drop-in center here at the clinic. We have a drop-in center where patients are invited to come in, share a cup of coffee and camaraderie. Magazines, some self-help resources are available, and it's a growing program that we're very proud of here. We approached patients and asked them if they'd be interested in participating in a 15 to 20-minute study. We received IRB, a waiver of consent to conduct this human subject study. And we approached 20 patients with this sort of, are you interested in participating in a quick survey? We'll pay you $5 for this. It's anonymous. And we were able to collect our data within a week. So we had extremely fast engagement. People were very interested in participating, and we got some good data. Our drug use demographics, so our participants had anywhere between 1.5 to 35 years history of use of heroin or opioids. And as we've heard from the other two sites, this is a recurring theme that most people are actually sort of endorsing fentanyl use, even if they're not really looking for it, but it's what's available here in Baltimore on the streets. About half of the population were intravenous users, and 85% had had at least one prior treatment episode prior to the intake here. And so going along in the same sort of format, we're going to discuss awareness and availability of naloxone, attitudes towards naloxone and influence on drug use behavior patterns, implications for education, and then I'll talk about some other noteworthy findings. Next slide, please. So in terms of awareness and availability, 100% of our participants knew about naloxone. Next slide, please. Perceptions of availability, about 85% think it's available and easy to get a naloxone kit. And when they were specifically probed, 65% could describe exactly where they would go to get a naloxone kit. 8 people said that they would go to a pharmacy. 4 people said between hospital or clinic they could find some. And then most people did find that community programs, sort of feet on the street programs do provide Narcan, and they know where to go to get these. A lot of people did have, sort of comments about that though. So one individual said, but I don't use, I'm clean, so I don't go there. Somebody else said, on the streets, someone will have it. So by and large, most people did know where to get it. Only a little over half currently had naloxone, or they owned naloxone. And only 4 people reported carrying their kit, physically carrying their kit with them. And one of those 4 people had actually reversed an overdose earlier that morning, that same day that we met with them. So some of the barriers that we identified to carrying naloxone at all times, inconvenience was a big theme. So people expressed that the package is just simply too bulky, the box is too big. Fear of punitive repercussions was another reason. One person said, I thought police would lock me up if they found me carrying it. Another person said, if the police come, they'd think I'm involved. Fear of violence was a big theme. So sort of this idea of being afraid of the person's reaction who is being reversed. I would only use it on people that I know. Location, so I don't go anywhere. I only use it home when I need to. So this was a reason for them to not carry it everywhere with them. And then the idea that resupply is uncertain. One person said, I used it and was supposed to get some more from my counselor, but I never did. In terms of attitudes towards naloxone and influences on actual drug use behavior patterns, 85% did not believe that people who had been revived with naloxone were thought of any differently by others. 60% indicated that naloxone has changed the way they and others think about overdose. So one person said, I feel safer. You can save someone's life. I've seen too many of my friends die. I'm glad there's Narcan, and people aren't as scared. But what about the actual behaviors, the actual drug use behaviors? One person said Narcan is good, but doesn't change anything. It doesn't change how much drug users are going to use. Another person said people are going to do what they're going to do. And by and large, most comments provided endorse the notion that although naloxone has changed the way people think about an overdose, it doesn't actually change the drug use behaviors per se. And indeed, we found that indications that people seem to think that some of this behavior change may actually be a positive thing. One person said, people I know actually cut back their use because they had to be reversed, and it opened their eyes. Fear is the best motivator sometimes. I got clean after I woke up on a ventilator at university. I knew it could have been my last day. I got clean that day, and I've been in the program ever since. Some perceived barriers to naloxone use, clearly knowing how and when to use. And so if you'll back up one, Erin, some of the comments that people supplied, people don't know when to use it. People should be mandatorily trained on how to use Narcan. So just not being fully aware of when the appropriate time to use naloxone is. Inhibition to use during times when its use might not have been necessary. So somebody wrote for us or said to us, people might be afraid of the overdosed individual's reaction to the reversal. It's not pleasant. So we've heard this sort of this idea of that extreme pain. I think Dr. Babu described it really well with one of her participants' comments about how painful and how horrible it is. Another person said they were scared of the OD'd individual's reaction to being reversed. Saving lives, yes, but the experience is so awful that they might not want to put them through that. Fear of legal trouble. This was a big theme. I didn't want to get in trouble with the police. Don't want to get caught up in this. If police come, they might think I'm involved. Another person, I thought police would lock me up if they found naloxone on my person. So not really understanding that the syringe, the needle, the sort of the paraphernalia that they, you know, it might be perceived as paraphernalia what they're carrying just for the injection. Implications for education or intervention, the cascade of care lens. So we had a particularly a very smart resident, Alexander Pappas, who worked with us on this project, and he applied a commonly used framework for understanding cascade of care where the gaps in care delivery might be found. And this is a paper from 2018 from Tobin's group, the International Journal of Drug Policy, who showed that you can apply the same framework to understanding where the dropout in naloxone carry and use might occur. So in that study, he showed that 90% of the participants were aware, about 70%, they had awareness of naloxone, about 70% had access, 60% had had training, about 47% had ever used naloxone, and a little under 30% had actually had naloxone in their possession. So he took this framework to apply it to this very small N of 20 to see whether these patterns held. And if you just want to flip through, yeah, so they were, you know, in our study, 100% of our participants were familiar with naloxone. 85% were finding that it was available and easy to obtain. 80% received training on how to use it. 65% knew where to obtain naloxone. 55% currently had naloxone. And only 20% consistently carried naloxone with them. So this is just a different way to state what I've already talked about, which is sort of the consistent carry of naloxone was a major gap that we identified. So in terms of opportunities for education, generally people are familiar with naloxone and what it is used for and encounter naloxone on the street and through various street and harm reduction initiatives, but fewer people have received training on naloxone use. Many expressed uncertainty on how to identify the critical signs indicating a need for naloxone. And indeed, 80% may actually be an overestimation, as only 65% endorsed having been exposed to a formal training program through a community resource or the clinic. And in fact, our own clinic that very day had held or that week had held a naloxone training class. In terms of the knowing where to obtain it, although the general perception is that naloxone is available and easy to get, the team, we all had the sense that people's knowledge of where to reliably and consistently obtain naloxone was just not evident. Knowing where to get Narcan is a big problem. One can only get kits from footwork, people giving kits out. And somebody else said, sometimes it's easy, sometimes it's hard to find. So the perception that for many, the naloxone has to come to them was something that came up over and over. And the idea that lots of people are too lazy to go out and get it came from one individual. So many people were unaware, additionally, on top of this, they were unaware that Baltimore has a standing blanket over-the-counter prescription for naloxone. So we're fortunate in the sense that we do have it, but for some reason, it does seem like the word might not be getting out enough. Some identified barriers to possession include, again, fear of legal ramifications. I don't want to get in trouble with the police if caught carrying it. Fear of being identified as an active user of opioids. I took it out of my bag because my grandson was over. They wouldn't use it anyway for fear of the overdose reversed individual response. I would be scared of getting hit or yelled at by an angry person who had overdosed. And in terms of carrying, we thought that we found some, areas, some target areas for education efforts. One is in the identification of an overdose crisis. So having people truly understand when it's appropriate. You heard a few minutes ago about the skin color and these kinds of things. People are just not really clear of when it's needed. Training on how to use naloxone. Information on where stable, reliable sources of naloxone can be found, and then education in terms of awareness of Maryland Good Samaritan laws and education concerning the legality of carrying and using naloxone. I feel like if that message alone were communicated more clearly, I think that would probably prevent a lot of the barriers, people just scared. So next slide. Some other noteworthy findings from this small sample. This treatment-seeking population has been extensively impacted by opioid overdose, both personally, like I said, 40%, and from having observed an overdose, 70%. 80% of respondents knew someone close to them, like a friend or a family member who had died from an overdose. 60% of the participants endorsed past or current engagement in harm reduction behaviors, things like doing test shots, fentanyl strips, observing peers of greater tolerance prior to use. So participation in these behaviors did not correlate with other behaviors relevant to naloxone use, things like proclivity to own, carry, or use a naloxone kit, but we think that there's too much noise in the data here, and an N of 20 isn't going to get us. And so we're really going to squarely focus on how to identify this as just one behavior in the repertoire of harm reduction approaches. So that I'm excited about that work that we're going to pursue. Participants' responses to the various sections of this survey revealed that they held largely favorable views regarding naloxone utilization. Interestingly, some participants provided answers which belied a stigmatizing view regarding how naloxone availability may change others' drug use patterns. So one person said it makes them more careless. People know that Narcan is going to save them. People might think it is okay to do these drugs, okay to get the fentanyl because someone will have Narcan. I wouldn't do more, but I think others would. And so, it sort of occurred to us that we're kind of unique in that we're approaching patients who are in treatment, who have been enrolled and are partaking in a medical treatment program for their opioid use disorder, and how much of this sort of internal stigmatizing might actually be influencing some of their thoughts regarding naloxone. So this could be another area for education opportunity in terms of sensitivity training to combat this sort of what my master's level research coordinator would call othering. And finally, many participants expressed a desire for more education and access to naloxone. Notably, many clients thought that treatment clinics should have a key role in these efforts, and I would wholly agree with that. This is the group. The three fellows who participated in this are at the front, Aaron Greenblatt towards the left, Dr. Weintraub towards the right, and then Tom Cole at the top on the right, and then Sophia Kozak. And again, thank you very much for this opportunity. This has been a fascinating experience, and we're really excited to continue. Thank you.
All right, thank you so much, Dr. Hoffer and Dr. Babu and Dr. Belcher. We really appreciate your presentations today, and you shared a great deal of valuable information with our participants, and I'm sure that has initiated a lot of thought and discussion amongst them. And so I encourage you all to submit your questions and comments through the Q&A box. Again, just as a reminder, don't try to raise your hand because we can't call on you that way. So please submit your questions in writing, and we will make the slides available on the NDU's website along with a recording of this webinar in a few days once we've had a chance to format and set up our recording. So I'll transition now into a Q&A session, and I will start with our first question, which comes from a participant who asked, do users carry multiple dosages since fentanyl typically requires multiple applications to be effective?
In the context of this particular study, we weren't asking our participants what their naloxone kit looked like. What I would say is that in the state of Massachusetts, we've seen this fairly rapid transition from the 2 milligram naloxone syringes with the atomizer to 4 milligrams, sort of the nasal actuation device, now to 8 milligrams. So when you go to a retail pharmacy or when you go to most syringe exchanges or like public naloxone distribution projects, you will see that patients are receiving 8 milligrams of naloxone to take home. Whether that's what they're carrying, typically, I'm not sure, but we do have some unpublished data as well that when we looked at 24 individuals who came into the emergency department, we had 4 individuals who received 8 milligrams intranasal and subsequently still required a rescue dose, whether intramuscular or intravenous. So I agree. Ideally, our participants will be carrying 8 milligrams of intranasal naloxone at a minimum, but whether that's happening or not in our community, I just don't know.
So just in Cleveland, I can say that we did hear a lot of reports of people using multiple doses and carrying multiple doses. And some of that, I think, is part of an issue of just training, right? So sometimes they administer a dose and they don't wait long enough for it to sort of take effect. And there's some knowledge of that, but the idea was to give more, I think, than sort of, if they had an extra dose, to just put 2 doses on a person, which I think is sort of interesting to think about.
Thank you very much for that information. Our next question is, do you think unrestricted over-the-counter naloxone, such as acetaminophen, will increase utilization?
Yeah, I think that a lot of that depends on the price point. And so right now, with the current distribution programs that we have free naloxone distribution through a number of public programs. We see that Mass Health is covering this for approximately $5, I think is the copay for patients who are covered with Mass Health. And then the private insurance, the range can be up to about $20 for the copayment. And so I think that one of the pieces of the over-the-counter argument, which I think that it will increase access with respect to just the availability, but again, in a state where you're able to get it at the retail pharmacies without a prescription because of this blanket prescription, as Dr. Belcher mentioned, in Baltimore as well, I think that the challenge with the over-the-counter piece is just whether or not third-party payers will be assuming the cost for over-the-counter medications, which is not what we typically see for things like acetaminophen or ibuprofen, or whether patients will be paying full price, whatever that over-the-counter cost looks like.
I just want to add to that too. I think even just gaining access, I mean, we're here in Baltimore in a very urban area, but sometimes even just finding the way to get to the drugstores can be problematic. And just getting in, and yeah, I think it would help, but I'm not sure that it would solve the problem entirely.
Did the study address, did any of you in your sites address or collect information about refusal of transport post-revival?
So this is something that is extremely pertinent to our practice in emergency medicine, because I think that a lot of our goals and our objectives recently have been trying to advance ourselves as a locus for overdose care. But in Massachusetts, we've seen our ED volume related to overdoses go down by about 12%. So we have a lot of interest in these patients who are, where an EMS call is placed that don't ever make it to the emergency department. This study is not designed in a way that, at least from the emergency medicine perspective, can address that, because we're already at we're assuming transport. But there's so much importance to that, and I think that there's great work to be done in that area. And I think it's an important question. Again, I'm sorry that we weren't able to address that here, but we're working with our pre-hospital partners, and we follow what Broach EMS is doing pretty closely on social media. Thank you for the question.
If you administer buprenorphine after Narcan administration, would that mitigate the effects of precipitated withdrawal?
I don't want to monopolize. These are all clinical questions that come to us.
Yes, that's great. So we're lucky that we have you here.
Thank you. The answer is we're not really sure. And so right now, our current guidelines through the Mass Hospital Association suggest that we're able to give buprenorphine, naloxone, or Suboxone as early as 1 hour after naloxone administration. In the hospital, I feel like, just in terms of sort of getting here and being seen and having a conversation, we're not usually reaching people within that 1 hour. When we find people here in our setting, we're often finding that they've had a period without drug use that led to their near fatal overdose. So I feel like the old days, where we used to see a lot more precipitated withdrawal in the ED, we're actually seeing in the patients that come to the hospital a little bit less of that. But there is an interest in the early induction of these patients with Suboxone, because we certainly don't think that we're going to make their withdrawal symptoms any worse, as long as we're kind of waiting them out long enough and we ensure that there isn't a long-acting opioid like OxyContin or methadone on board.
Okay, thank you. So we're moving away from the clinical area a little bit now with this next question, which is, did participants report experiences of stigma when trying to access naloxone at pharmacies or any other access points?
I can talk, at least in Cleveland, most of the people that we interviewed accessed naloxone through sort of community-based programs. And so we didn't find a lot of people going to the pharmacy or going outside of those venues to acquire the drug. And so I think it's a really good question. I think that's one that needs to be answered definitively. But for us, people seem to have access. They did seem to take advantage of that when they knew it was around.
Just to let you guys know, our next webinar will be on November the 26th at 2 p.m. Eastern. That's the Tuesday before Thanksgiving. And this one will focus on perspectives on cases of e-cigarette or vaping-related lung injury from 2 poison control centers. So look for our announcement on the NDUS network and register for that one, and we'll see you again then. And coming back to the questions, our next one is, within these 3 studies, is the use of Narcan being reported and tracked in any way as to if the medication was successful in reversal. I know that wasn't really a part of the end-use study that we did, but I don't know if that was anything that any of you had an opportunity to look into in other ways.
We don't have those data as far as I'm aware in Massachusetts. There's some really outstanding data available on the mass.gov website that talks about by county and by city how many patients called 911. So how much pre-hospital engagement there was compared to how many patients presented to the emergency department. We do not, as far as I know, have system or statewide data on naloxone utilization by pre-hospital personnel, and trying to get data on bystander naloxone and that utilization I find is even harder, other than sort of self-report at this point. With respect to the question of successful reversal, it's really interesting because some of the forensic testing that's available can find naloxone, and some of the work that we're able to do right now is able to identify naloxone in biological specimens. And so I think that one of the interesting questions would be whether that's something that in your community, your medical examiners are including as part of postmortem toxicology, but that is not a standard inclusion in Massachusetts.
All right, thank you. We have just a couple questions left that have come in. And so in the meantime, I'm also going to go ahead and launch our brief poll, because we always like to get some feedback at the end of our webinars and some suggestions for future topics. So I would appreciate it if those of you who are still with us would take a few seconds to answer about 3 questions for us. And in the meantime, I hope that you have all found this webinar to be useful and that you have gotten some valuable information from it. And certainly we appreciate the hard work of our colleagues on doing their site studies and preparing their reports, which are, again, all available on our NDUS website at www.ndus.org. And you can learn more by looking at the reports about their methods and what they found, and also about the process that we all work through together in NDUS and how we were able to successfully develop a method for rapidly collecting information on important and timely substance abuse topics by developing standard domains and questions that could be used across different kinds of studies and populations. And so coming back to our last few questions here, our next one is, were there noted or observed racial implications about fear or trust in the Good Samaritan law? Did any of you happen to get anything relative to that?
Well, I don't know about the racial issue, primarily because of the sort of the predominance of basically non-Hispanic whites in our sample, but I can tell you that people don't trust it. And I think they don't trust it because of this issue where, you know, a person might not be charged for the event that the police come to, but they might have outstanding warrants for something else. And most of the participants that we interviewed did. And so they were very concerned about that. And so I think the trust might be sort of, you know, it's blurry here, right? They might trust the actual, I mean, the Good Samaritan law might be actually working, but people are still going to jail when they call the police in these matters for other reasons. And so I think that's really problematic for at least a lot of the participants that we interviewed.
Yeah, I mean, that's perfectly well stated, Lee, and that's exactly what I was going to say. I can't imagine that there isn't some component of that. We didn't actually specifically assess this, but I'd be surprised if there isn't a huge amount of that happening. So, yeah.
Okay, thank you. So our last question for this afternoon comes from a participant who is wondering if you have any thoughts or suggestions about how we could encourage or improve people's willingness to call 911 after administering naloxone to someone.
I think I think it's an awesome question. There's just so many different layers to it. And so I think that part of the the thing that discourages patients from coming to the emergency department is stigmatizing or difficult interactions that they've had with either pre-hospital personnel or hospital staff. So we work on destigmatizing interventions with our teams. But the second thing is that in our community, the emergency medical services experts really have looked at this as an opportunity to provide outstanding care to patients with opioid use disorders. And so on their own, developed some resources, specifically business cards with the state hotline number, with directions and the phone number of our bridge clinic, with resources that links to Narcan CPR videos to distribute to patients and their families if they're refusing transport. One thing that we don't have in Worcester right now, which I think is the most progressive version of this, is there is a follow-up door knock or phone call by community agencies or by recovery coaches embedded with the police the following day. So I think there's a lot of different ways that this can be much, much better at every phase of the interaction, but it's something that we're working on all the time.
Yeah, I'd like to follow up on that too. I think this is a really, really difficult question because, when someone calls EMS and they're treated in a way, or they're afraid they're going to go to jail. Those are challenges. I think there's also the issue that a lot of times when people are reversed, their peers just think they're fine, so there's no need to call EMS. So we experienced that in a number of sort of narratives. And then the last point I'd like to make, I think, which is really a challenging one, is that how law enforcement and EMS are connected here can sort of turn some users off, right? So, a lot of times, at least active users aren't really interested in the police coming and knocking on their door if they've overdosed, previously. And so I think there's some challenges there that are really going to be hard to address, because we don't want any unintended consequences of people saying, well, you know what, if you go to the ER, the next day a policeman's going to come to your door. And so I think that's the challenge there, even though I'm not saying that law enforcement doesn't have honorable or, medical intentions and want to help here. I think it's just going to be hard for users to overcome, decades and decades of being treated in a certain way by law enforcement.
All right, thank you very much, everyone. And just a last reminder, yes, the PowerPoint slides and a recording of this webinar will be available on the NDUS website, www.ndus.org. Look for them under the resources tab. And also, if you have time, take a few minutes to check out our individual site reports prepared by Dr. Hoffer, Dr. Babu, and Dr. Belcher and their teams, which are also available on the NDUS website. And we hope that you all will join us again on November 26th at 2 p.m. Eastern, when we will be joined by the medical directors from the poison control centers in Pittsburgh and New Jersey for a conversation about e-cigarette or vaping related lung injury. So have a good day, everyone, and we will see you again next time.